So today we are very pleased to be hosting a fireside chat. The title is Type 1 Diabetes Prediction and Prevention. And together with us, we have as moderator, Dr. Al Powers. He's the Josie Davis Chair in Biologic Science, Professor of Medicine, Molecular Physiology, and Biophysics, and the Director of the Vanderbilt Diabetes Center. He's also the Chief Division of Diabetes, Endocrinology, and Metabolism. He will be moderating the call in the fireside chat. And then speaking will be Dr. Bill Russell. He's the Cornelius Vanderbilt Chair, Professor of Pediatrics, Pediatric Endocrinology, and Professor of Cell and Developmental Biology, Cell and Developmental Biology Director in the Division of Endocrinology and Diabetes Pediatrics. Also, we have Dr. Dan Moore. He's the Associate Professor of Pediatrics, Pediatric Endocrinology, and Associate Professor of Pathology, Microbiology, and Immunology. These three individuals are very well suited to discuss the issues surrounding T1D prediction and prevention, and we're very happy to be here at Vanderbilt, which is, you know, an iconic place for T1D research and clinical application. So thank you very much for joining us, and we're really excited to get the fireside chat going. If anyone has any questions, please drop them in the chat during the talk, and we will field them as we can. You can also feel free to raise your hand in the chat and we'll address you as well. Thanks again for joining us.
So Monica, Alex, and Sugar Science, it's really great to have you guys here at Vanderbilt. The work that you do to connect scientists to enhance and accelerate research is really important. So we're honored here at Vanderbilt to be part of that. And so we've chosen a topic today that I think is very timely, very topical, is front and center around type 1 diabetes. And I'm delighted to have my two colleagues here who are really quite expert in this area to share their wisdom and to pontificate. I would like to emphasize what Monica said. We'd love to have audience participation. So if you raise your hand, what we're going to do is have about 4 or 5 questions that I'm going to pose to Dan and Bill. I'm going to try to provoke them to think about the controversial areas, to think about gaps and that sort of thing. We'd love to have people from the audience join with that. So as we are going on with one question, before we go to the next question, if you would raise your hand or put something in the chat, we'll call on you. We can unmute you so that you can actually speak your question, or we can read your question for you. Okay, so great, let's get going. So Bill and Dan, just so that people that are listening know who you are and your background, would you give a little bit more about your role in type 1 diabetes, especially as related to prediction and prevention? Bill, maybe we'll start with you.
Sure. So I'm the director of pediatric endocrinology and diabetes here at Vanderbilt. I've been here since 1990. I've watched our program grow to be a very large one. We follow about, at last count, 4,100 children with diabetes in our pediatric program. They eventually move on to adult care, but it's a great opportunity to be kind of in the center of a large area that does not have a lot of other resources for type 1 diabetes. To have them all come here, it facilitates our participation in things like TrialNet. I'll tell you about that in a moment, but we've had great acceptance over the years of patients volunteering for trials, so that in about 80% of our overall population of children with diabetes is type 1, even though this is the South, we're the buckle of the Bible Belt and the obesity belt and all the other things. We still kind of act like we're Finland or something in terms of the number of patients with type 1 diabetes. It's a population that I'm sure you all know is a very tightly organized, tightly knit population.
And I did my PhD in immunology at Penn, and I'd grown up kind of as diabetes had grown up, understanding that diabetes is probably, at least in part, an immunological disorders that inspired me to really focus on that. And I feel that maybe a really good position as more immuno studies and immunotherapies have come online for type 1 diabetes. So I've been excited to be here with Bill doing a lot of the trauma studies alongside him as we've enrolled patients in all of those. And then with the recent launch of Tezio, leading with him and Dr. Gregory, the immunotherapy clinic here at Vanderbilt. I also run a lab that does basic science studies in little mice. And as I talked about yesterday, MRI studies for translational biology.
So it's great. So let's talk about the prediction part of this first, right? So, there's lots of things going on over the last few years related to being able to predict type 1 diabetes well before it manifests itself as hyperglycemia. There was the TEDdy trial. TrialNet has been involved in that. There are also trials that involve that are happening in Australia, looking at sort of environmental determinants. There are things happening in Colorado and Germany and UK, and so population-based things. So could you tell us where you think we are with screening, especially general population screening, because TrialNet is focused on first-degree relatives and that screening. So I feel like people know about that. So where is the world around screening in population base now?
Start with that. So I think at this point, genetic screening is not ready for prime time. There are multiple loci that are high risk, but as far as predictors of who's actually going to get diabetes and who are people that you'd want to identify in enough time to have an intervention, it seems that antibody screening is still the primary agent to
So I'm going to come back, Bill, and talk about the genetics, because we'd like to hear more about how you think it might be, when it might be ready for prime time and what's needed. So in terms of general population screening, you still think antibodies are the most
yeah, they offer you a window. It can be as long as multiple decades in when people acquire the antibodies in adulthood. In childhood, it's a matter of sometimes weeks to months between the acquisition of antibodies and progression to stage 2 or stage 3, stage 2 being antibodies with abnormal glucose tolerance, and then finally diabetic glucose tolerance. But yeah, that still seems to be the most useful tool at this point.
And Dan, would you agree with that antibodies at this point are the most useful tool?
I actually wanted to comment a little bit even on the question. Like, it's a really interesting question. It's like screening really, right, means identifying people before they have the disease. But the way we understand the disease now is once you have 2 antibodies, you have type 1 diabetes. You might not have hyperglycemia today. So really, if you're thinking about screening, you have to find people before they have multiple antibodies. We're not very skilled at that yet. Genetics is probably the answer to that. We do know a lot about the genetics now, but implementing that and driving that in a cost-effective manner, we're still probably a little bit of ways away from that. But studies like in Germany and the AST study in Colorado and the other studies, I think, are going to pioneer the way for that. And then you look at general population screening to find people that have the diagnosis and don't know it. It's a challenging question. It's probably not very cost effective yet. Like, it's probably very hard to find people. If you're a general pediatrician screening people, you're gonna have to screen hundreds and hundreds of your people to find one. And probably what's going to happen to you is you're going to screen hundreds of people, not find any of them. And the one kid that walks in with diabetes is the kid you didn't screen. It's going to be really defeating for general pediatricians, right? It's going to get hard to implement and maintain. And also, they don't have antibodies today. It doesn't mean they won't have them in 6 months from now. So how are you going to implement this? But we have to think about it, right? We have to make a plan to do it, because kids shouldn't get DKA and kids should get the opportunity to have their diabetes prevented.
So both of you would agree that antibodies in 2024 are the most effective screening tool that we have for something related to diabetes. I think your point, Dan, that the disease has already started. We're not really preventing it. We're trying to modify its course by doing that. And so both of you would agree that antibodies are probably the best way to do that. And so, Bill Russell, you talked about the large practice you have here. There are other large practices around the country. So how are you beginning to think about screening from a population-based point? How do you do that?
I think it's difficult, and there are some examples. Munich and Italy apparently has a program, Australia, but right now there are the issues of who's going to pay for this, TrialNet is funded to find ways to prevent type 1 diabetes. It focuses on family members because that roughly increases the rate of identifying individuals. If you take the general population, Dan mentioned you'd have to screen a lot of people. It's like 250. It's about 1 in 250 that you're going to find positive antibodies in a general population pool, where it's 15 times higher. It's about 1 in 20 if you screen relatives. And so, because it's expensive to do this properly, it's expensive not only to identify the people, and then there's the whole follow-up infrastructure about what do you do when you identify these people. This wouldn't be something that general pediatricians would do. So I think that those are some of the impediments to.
And so what, Dan, what is going on here at Vanderbilt and how it compares to, say, other places around the country? Are you actively screening people? And if so, how are you identifying the people to screen?
Yeah, I mean, I think as we talked about it, the cost effectiveness is hard. It's costly to screen people. It's also costly not to find people with new diabetes. I mean, I think about it in layers, like the inevitable onion. Like, first, we have to screen everybody that's a first or second degree relative, right? Every single person that comes into the adult endocrinology clinic that's an adult with new onset type 1, all of his little nieces and nephews and cousins in Wisconsin, they all have to be screened, right? That's the most efficient way to do it. Every new onset kid that comes into our clinic, every sibling, every relative, every uncle, every person, like that's where the yield is, right? And then there's areas that are being identified of like lower yield, but still higher than general population. Like if you have a strong family history of autoimmunity, a lot of thyroid disease, a lot of celiac disease, probably you should get screened. And then, but still most of the cases are still going to be in the general population because the general population still outnumbers all these people vastly, tenfold over. And so how do you get it there? There's not a great answer to that yet. I do think ultimately genetic tagging of people at high risk, like, oh, this person has a high risk score, they should get screened every year, is probably true, but probably will still miss people. There's, minority populations have different genetic risk factors and scores. Those are not as well accounted for in genetic studies. So are they going to be left behind as screening moves forward? And like, what is their obligation to different populations to get this to everyone in an equitable way? It's a lot of tough questions.
And are the assays for the autoantibodies standardized enough that if they come, say, to see you at Vanderbilt or they go to another major center, that center has identified assays that are reproducible and predictive? But is that true of other assays that are available? Say if someone orders a GAD antibody in a clinical lab, is that assay sufficient for screening?
Yeah, I mean, assays do continue to improve, and definitely that the leading research centers, they get more sensitive and more specific, but I wouldn't cast any aspersions on the available clinical assays that are there. If you're positive for one of those, you should get follow-up.
Well, I'll make a comment there, though, in that if you don't have a family member or your proband in the family has developed, this was a problem at the beginning, type 1 diabetes clinically, but they were over the age of 40, they didn't qualify as the proband. That's all been modified now, so that if a child gets a positive test in any of the commercial assays, they're eligible to screen in TrialNet. And I'm not prepared because I really don't know the data, but I've been at meetings where it's been reported, the concordance between a positive assay in a commercial lab, and again, it might be just a single one, might be a couple, the concordance with positivity in TrialNet is not always very strong.
It's not very strong.
Is not. And is not.
Is that an assay issue, or is it the fact that those autoantibodies can wax and wane?
No, these are probably in the course of time, but relatively close together. It's an assay issue, as far as I understand it. So it's just that's always an issue. That what you measure in a commercial assay may not. And we use TrialNet as kind of the gold standard at this point, but I would assume over time.
So we've got a question for the audience.
Hello, very nice discussion. I'm Khyati from Boston College. I have a question regarding how do you determine the age for the screening, or it's just random? Or what is the frequency? Like, it's not like you screen one time, the person is negative, and the other time it will be negative, means it will not be positive. Great.
So let me just repeat that to make sure everyone heard that. The question is, how do you view age? What when is that a factor? And do you screen on somebody when
I'll
they're
throw in a
sick?
quick perspective. Their TrialNet starts at 2. I think Munich, where they have universal screening now, so not just relatives, or where they've experimented with this, started at 2. We know that in general, the standard type 1 is not present at birth, but you know, and in general, the dogma is you don't see type 1 until about 6 months, as young as 9 months of age. And so if you're starting your screening at 2, you know, the yield is going to be low if you started in 6 or 9 or 12-month-olds, but you're going to miss the people that are going to be presenting with possibly even ketoacidosis by the time they're a year old. So it's.
And what about the upper level of screening? So here you're saying go younger, but what, you know, is there a
comment on
time
the upper
where
level.
screening should
I
be
think we need
stopped?
our adult people to be a little bit more open to this.
I mean, we run, like, these questions are very difficult. We run a little bit into like the perfect is the enemy of the screened, right? I mean, there's not going to be a perfect cutoff and guideline though. And I think there's we're going to think about the research versus clinical application. Like, research studies are designed to be efficient because they have a limited amount of funding. So they have to only apply themselves to the people most likely to give yield. So TrialNet cuts off around 40 or 45 just because the yield is tapering. But people over the age of 45 get type 1 diabetes, and they, you know, they probably deserve to be screened, especially if there's a reasonable rationale for that. They show up with new diabetes, if they have a family history of autoimmunity, but it's not going to be perfect, and it's not going to be perfectly efficient either. I'm going to tell a story here to help people think, right? So I've had type 1 diabetes for almost 50 years, right? So I lived through the 70s and the 80s, you know. And so when I was young, right, my pediatric endocrinologist, Dr. George Bergen at Le Bonheur, thought you should give 3-4 shots a day, right? But not everybody thought this, right? Some people thought you give a bunch of shots, you're going to be low a lot. I was low a lot, and that's, you know, not going to be good for you. And people get complications regardless of how well they're controlled. And we just really shouldn't worry about it. We should just kind of keep them out of DKA and do our best. It wouldn't be until 1992 that we would have the DCCT trial run here at Vanderbilt, which would prove that keeping your blood sugar lower was good for you. And so people before that, 80, you know, years before that with insulin, had to decide, should we be aggressive or should we not be aggressive? And that's a question I think that's confronting us now in endocrinology, is how aggressive do we be with screening to benefit the being kept out of DKA, giving opportunities for immunotherapy benefits your future, but we don't have all the answers today. And we really have to think hard about how to employ this in a way that's just useful, a little bit efficient, but also maybe a little bit like liberal in the sense of we may need to do a little bit more than we need to in order to benefit the most number of people.
And that's great. And so, and let's go back to this issue of age, because we know that now a sizable number of people who develop what seems to be type 1 diabetes do it over the age of 18, right? And they're adults. And so
It's half of them.
yeah, do you think that that type 1 diabetes is different than type 1 diabetes in a 7-year-old?
Yeah, I think there are definitely some evidence of immunological differences that exist. Whether or not that's because of the response of people, you know, at that age and what can be measured, or the diabetes is fundamentally different, I think we don't know. Could there be differences like we look at in the MRI study with what kind of pancreas they started out with and how fast they progress? There's just a lot that we don't know. So I think there's definitely, there is a range of diabetes probably at all the age when we think about endotypes. And stuff, that not everybody's diabetes, even at every given age, is exactly the same, even though there's a lot of shared features there.
All right, so Bill, let's press on with this a little bit more. So someone who develops type 1 diabetes at, say, the age of 27 and had autoantibodies, when do you think those autoantibodies appeared?
Well, I think there's one really great study. It was just a letter to the editor of the New England Journal of Medicine from George Eisenbarth and I think Maria Redondo, with identical twins. And I use that to teach a lot because I think it tells the world about this. When the initial proband was identified, it fit exactly what we think about type 1 diabetes. The incidence peaked sort of at between 10 and 15, tailed off though well into adulthood. But if you look at the identical twin, most of them developed so they measured autoantibodies. So there's a second bar on the graph that looks like when did the second twin get antibodies? When did the other twin then go on to develop clinical diabetes? And it's just as you'd expect. In younger kids, the second twin, the majority of them started to do it as less than teenagers. And the gap between acquisition of antibodies and clinical disease was relatively short, years. But then you look further as it plays out, people are identified who acquire antibodies in their 40s, 50s, and 60s and have a 20-year latency between the antibodies and the acquisition of disease. And it points out how the older you get, it is a latent disease. I don't even pretend to be an expert. I think LADA is type 1 diabetes with a greater latency. I don't know exactly what causes the latency, but I've got to say I've been impressed lately. I've been reading Sarah Richardson, some of her data about structural changes in the pancreas that seem to be one of their manifestations of these structural matrix changes is access of the immune system to cells in the pancreas. So I think they're the same disease. Latency at first, I think people were thinking, oh, it's got to be puberty. It's not puberty. It's not sex hormones. It's something else that I think is happening in the pancreas. I think it's the same process.
And Dan, how does that, we talked about general population screening. You made the statement that half of them are adults. How does that factor into your screening, which is focused mostly on children and adolescents at this stage?
Yeah, I think there's just sort of going to be an ongoing history of how we deliver this and how we implement screening to the right people at the right time. I think some practices, even general adult and general pediatric practices, maybe they have a provider there that has type 1 diabetes. They might be more aggressive and screen more people. There's scientific data, of course, like TrialNet and these studies you mentioned, but I do think there's going to emerge a practical experience with screening, that people are going to do this and not do this, and we're going to amalgamate data from those sources as well to understand what's successful in the community. We mentioned earlier, like the more risk factors you have, autoimmunity, if someone has genetic things that have been studied, those people probably more obvious that they should be screened, but still most of the people are not going to have probably things that we measure in the current day.
Really challenging. So we talked about screening in 2024. Let's go 5 years in the future. How do you think screening will be at that time? What are the new ideas or the possible advances that are going to increase our ability to screen?
Let you keep going here.
Yeah, 5 years is awful short,
All right,
Like
okay, 10 years.
If you grew up
2034.
If you grew up as a kid with type 1 diabetes, like in my age group, you were told the cure was 5 years away every 5 years for like every visit you ever had. So like 5 years seems very short, right? I think we are probably gonna see better genetic identification. I think this is gonna have to be batched with other advocacy pieces, like genetic screening at the newborn level, not just for type 1 diabetes, but for other polygenic disorders and even other common monogenic disorders, as opposed to like sort of analyte-based screening that exists today. Then we would know this child is at high risk and their pediatrician should know that, and they should be followed, or maybe an endocrine practice would intercede there depending on the numbers. And
so you could see that, soon we're all going to have our whole genome sequenced, and it'll be on, some card that we have. It'll be part of our electronic health record. Do you think that is going to play a role in screening?
I think that's the thing that makes the screening most efficient, if that's the goal. You could imagine other scenarios. You could have a clinic that, saves all its serum samples for the week and like batches them and screens and says, did we have any autoantibodies this week, and recall all those people and rescreen them specifically for antibodies. You could do other kind of batch-based work, but none of those things are being done right now. The thing that is being done right now is better exome sequencing and better polygenic risk score identification. So probably that's where the opportunities for implementation are going to arise.
Bill, anything you want to add to that?
No, I think in 5 years or even 10 years, I think progressing to more universal screening, if you rely on family members, I don't think we've made this clear. It's pretty clear. It's really 90% of people who are diagnosed with type 1 cannot identify a family member with type 1. So they don't meet the TrialNet criteria of family member with T1D. TrialNet's acquired a good bit of data now on people identified as family members and non-family members to be pretty confident that it's not a different disease from if you have a family history of it. 90% of people don't have a family history. And I think if we're going to make an impact, screening for antibodies within, of a broader population, general population, is probably the short-term future. Dan outlined all the other nuances that we can build into this, but I think identifying more people than just family members is key.
I think, Dan, what you were implying that as screening, it should be part of a broader effort to identify people who are at risk for multiple diseases, not just type 1 diabetes, rather than focusing on, we're only going to screen people for type 1 diabetes. Is that what you were proposing?
I think that's our opportunity to band with other, people that have diseases. I mean, type 1 diabetes is relatively common, but still most people don't have type 1 diabetes. And by banding with other disease foundations and other disease advocates, that's probably the best way to get something implemented. Maybe the political headwinds will favor us and we'll get like more universal healthcare and stuff here too, which, they could follow the Munich, Germany model and everybody could get more screening, but we're not there currently.
Okay, so we have a question from the chat. Could we unmute you?
Hi.
Yes, we hear you. Please go ahead.
So how can the genetic risk assessment tools be improved to provide the more accurate predictions in case of type 1 diabetes?
Referring to genetic tools or antibody improvements, or what were you asking about?
Genetic risk assessment tools.
Dan, Bill, you want to comment on that?
Yeah, I mean, I think probably the most important sort of next steps is really making sure that the data sets that drive them are very inclusive and very expansive so that it's not sort of homogeneous populations that are often in these large scale genetic cohorts so that they can deal with sort of the variety and diversity that are going to be in the general population assessments. It certainly is nice to have the focused data sets that we have that allow easier identification of some of the risk factors, but that's probably going to be a key piece. And then sort of, as we mentioned before, I mean, I think there's going to be a little bit of a QI element to all this where people go out and they use it, like people like in some practice gets really motivated and they start doing these things and they gain experience with doing it. It's not necessarily a scientific driver of improvement, but a logistical and practical driver of like what questions come up, what goes wrong, how do we interpret the things, how do we deliver this information, how do we then follow up people that are identified that move, across states, or it's for some of the people, as Bill mentioned, it's a lifelong process before the type 1 diabetes arrives, and how are we going to keep them safe and monitored?
So you mentioned about the large program you have, and I heard you mention an intervention. What did you call it? Immunomodulatory? Immunotherapy clinic. That's part of the diabetes program. So that's a new concept. But tell us how in the screening process, how do you explain that to patients and their families? Let's say if they don't yet qualify for immunotherapy, and what's been the acceptance for that, or how have families and individuals dealt with that? I guess we should call them patients, but some people might not think they're patients, even though they're autoantibody positive, and we think they have the disease, but they don't qualify as a patient in the way that
they do. Actually, insurance accepts them as patients. I see. There's an ICD-10 code now for
autoantibody positive without diabetes.
Stage 2. So
autoantibody positive with diabetes. They have diabetes.
Well, if they have diabetes, but if they don't have diabetes,
they all have diabetes.
They don't have hyperglycemia.
Yeah, stage 1 and stage 2 codes now.
Okay.
So the FDA approval of Tzield is kind of changed things. We were kind of prepared for that because we were heavily involved in the TN10 study that actually did TrialNet teplizumab study that kind of laid the groundwork for this. And so it's a very limited group. It's people at stage 2. You have to have 2 positive antibodies. You have to have dysglycemia, but not normal, but not diabetic. You don't go over 200 in an OGTT. Your fasting glucose is not above 126. That's a small group. It's hard to identify. They're asymptomatic for the most part. And yet there's been people. So, but they don't just kind of walk into the office saying, I've got stage 2 diabetes. It means that somebody has actually thought about this. And it usually comes that these have been people that have been screened and identified as stage 2 in TrialNet. And again, as part of TrialNet, we have to explain to them, we have to, it's our duty. And I think moral obligation to say, all right, what else is available? We have a trial ongoing in TrialNet for stage 2 diabetes. It's not recruiting well. It's actually on pause at the moment, but it has not recruited well because a lot of people have said, but there's this FDA approved drug and it's been, in our experience, it's been well accepted by insurers to go ahead and give a course of teplizumab to 14 days of infusions to people at that stage. The issue, when I explain this to families, I point out, we know this group well. We have a lot of them here. We know the networks, networks involvement in this. Not everybody's a responder. The effect of teplizumab delaying progression of type 1 diabetes from stage 2 to stage 3 is different from the treated group to the placebo group, but individuals vary greatly in there. Nobody reverses their stage. Nobody goes back to stage 1. Everybody, for the most part, progresses to stage 3. There are still people that are being followed here. We've got one person who was in the placebo group at stage 2 in 2011, and they're still at stage 2. So statistically, 85% of people at stage 2 will, within 5 years, be at stage 3. So there are some placebo outliers. There are people who got the drug who didn't seem to respond well. We're trying that. A number of people are working on identifying those people immunologically to say who's a responder. But we've offered this clinic for that purpose. And when you say, are they patients or are they subjects? We also offer the opportunity to participate in other studies that have been initiated here by Dan and other colleagues in the group. Okay, as long as you're going to be getting this drug, we'd like to look at this too. Is this okay too? And I'll
Right. Okay, so now you both brought up sort of the clinical trials, and I think that one of the frustrating or kind of, maybe frustrating not the right word, but it takes a long time to get an outcome in clinical trials. And so the metric that is commonly used is a mean or an average C-peptide and the change in that, right? And so can you talk about some of the challenges of that and how there might be more surrogate markers or proximal markers that might indicate whether someone is responding to that rather than a mean C-peptide for the group? So comments on that?
Yeah, I mean, people are certainly thinking about this. I mean, C-peptide's probably going to be the gold standard for a long time to come because that's the thing that benefits you, right? That's the thing we know that you get benefit from. If you have more C-peptide, you have less hypoglycemia. If you have more C-peptide, you have more beta cell function. If you have more C-peptide, you're less risk of complications. So, I mean, we're going to need our friends at the FDA to be excited about some other marker, which we're probably going to need to demonstrate highly predicts the C-peptide, which currently most markers don't really. You can identify some responder, non-responder characteristics immunologically, but they're not like perfectly predictive, and they don't account for most of the variance in C-peptide that people get. And then, the FDA so far has been relatively friendly on the C-peptide outcome, but hasn't had any other outcomes initiated. The other thing you can think about, though, so your question is sort of broad in the sense like it takes a long time, right? So another thing you could think about is, could we identify people that are getting type 1 sooner? Like they're going to get type 1, stage 3, type 1 in 2 years instead of the 10 years for Bill's placebo patients, and we could homogenize those people. Maybe that's not as good for generalizability. We may lose something there in terms of treating all possible people, but we could get potentially quicker answers to some study outcomes. So say like in our MRI study, if you have a small pancreas, you are the next person to get type 1 diabetes. If you have a big pancreas, it's going to take you longer. So if you stratified a trial on that, we could say this is going to go faster. But it doesn't mean that, the small pancreas people's data would be necessarily applicable to the big thing. We'd have to infer that that was going to be the case, which would then need more studies. And then, of course, there's enrollment. Getting studies enrolled really quickly is probably the main limitation of making them go faster. And having all the follow-ups completed.
So both of you, sounds like you're predicting that some version of C-peptide will continue to be the most common metric for the effectiveness. Is that right?
I think so. I mean, I also worry a little bit too about things that are like in general, when you give an immunological thing, your goal is to protect beta cells, and you want to measure something that's directly connected to the beta cell function. Everything else is secondary, right? Everything else is 1 or 2 degrees away from that. So maybe it changes, maybe it doesn't change, but that's not the direct measure that you're trying to affect. Like say you measure A1C or hypoglycemia or something. Well, that's confounded by like your endocrinologist's good intentions to alter those things themselves rather than being a direct measure of beta cell function.
A number of clinical trials have kind of fallen on the rocks when their primary endpoint was improved hemoglobin A1C. And Dan just gave a reason. Now, one thing that's been tossed around in TrialNet is we've got people now on smart pumps, hybrid closed loop pumps, and where the operator, well, so there's still a lot of operator issues there. It's not whether your endocrinologist says, I think you need to change your basal rate. Think you need to change this or that. The pumps will do a lot of that stuff, but then you have a participant that's actually going to enter carbohydrates at the beginning of the meal accurately and, follow the rules. But that takes some of the physician variability, like clinical variability, out of it. If you could put them on a closed loop system permanently, then you could start looking at hemoglobin A1C, but that's
Right.
Other things. There are metabolic indicators. There's the index 60. There's a DPTRS score that takes factors like your BMI, your age, and they're complex, equations, but that can identify quicker progressors. And so we actually have a study that had built in more rapid progression with, I don't know, index 60, I can't remember which one, but something that said, yeah, you meet the criteria for this stage, but in addition, we want you to have criteria that are going to say you're going to progress faster so that we don't spend a decade kind of doing it.
So speaking of interventions, beyond any CD3, I mean, a number of things have been tried and talked about it in combination therapy. Make a prediction over the next 3 to 5 years. Anything else going to be added to that, or?
I'll let Dan is our combination therapy man.
Yeah, I'm with Steve Gittleman at UCSF. I'm the co-chair for the TN25 study, which is rituximab and abatacept together. It's the first combination therapy done through TrialNet. The idea is you deplete the B lymphocytes. Rituximab showed a positive response in its study 2 decades ago now. Abatacept that Dr. Russell has led has shown positive responses in a couple of studies, and maybe together they can further tamp down the autoimmunity. But I think this is where we're going to go. You're going to have to get to combinations because there's no real reason to think that in a polygenic disorder that covers at least 50 genes, that like one cell, one pathway, one thing is the answer to the whole thing. That's kind of a ludicrous proposition. The other thing that I think about, so say we're very anchored to C-peptide and stuff, I think about trials that didn't meet that endpoint, but those drugs, those pathways might be necessary for diabetes, but not sufficient. So we may have thrown some babies out with some bathwater in the past. We may be at risk for doing that by not saying what do we want to accomplish? What do we want to do mechanistically? And are we doing that? Do we move the Tregs? Did we deplete the memory cells? Did we eliminate the antibodies? Did we improve beta cell function as measured by some sort of stress marker? And if we did those things, that's probably a component of a good therapy, even if it didn't hit the actual C-peptide, let's go to clinic today kind of approach. So I think there's a place to think about, what we want to inhibit this cytokine. What do we want to do? Did we do it? And then do we put those things together to see how effective they can be?
Yeah. So we have a question online.
Hello, the question is regarding are there any future plans for non-autoantibody patients? How are you gonna screen them? Where the research is going in that way? Plus, what about new onset T1D trials?
I think I'm not entirely sure I follow your question. So there are, individuals with diabetes that don't have antibodies that have flavors of type 1 diabetes. Those are often good study candidates for other studies like the RADIANT study that thinks about rare and atypical forms of diabetes if you're just not sure what kind it is. Some of them have monogenic forms of diabetes. So our colleagues at the Kovler Diabetes Center in Chicago have a monogenic diabetes registry if you think you have that kind of thing. And that gives us a lot of insights into, things, single pathways that break down that give you diabetes. There probably are a few percent of people that have antibodies that we don't measure or just don't have them when they are measured that have type 1 diabetes. I think with genetics and other things, you might identify those people as having a risk score in the future, and they might then be eligible for interventions, probably interventions that have already been through studies and been approved. I think it'd be very difficult to enroll them into studies that are trying to keep a classified list of patient characteristics. There, of course, also the TN25 study I mentioned is enrolling in new onset individuals. Generally, most of those roll in the first 100 days after diagnosis. TN31 in TrialNet is a JAK inhibitor study that's enrolling. There's also studies through other organizations as well that are in their pilot stages, trying a variety of different kinds of immune-based therapeutic approaches to the new onset period. Trials tend to be limited to the new onset period because you have relatively more C-peptide to save at that point. It doesn't necessarily mean that if you still had C-peptide 6 months down the road or 9 months down the road, the trial wouldn't be good for you. It's just harder to organize trials around those time points.
Yeah, that's really helpful. So I'd encourage the audience to ask questions or raise your hand. We'd love to have more discussion about that. And so one of you mentioned the word registry. So in the United States, in contrast to, say, some of our Scandinavian colleagues and countries, do we have any type of registry for people with type 1 diabetes?
I don't know. I know the world I live in, and TrialNet is a good one. In other words, it's like newborn screening. We screen every newborn for, and here it's about 45 different disorders now. The key is not just to do the screening, it's the follow-up that is really critical. In other words, identifying these people and making sure that they get the follow-up care that's appropriate. So a registry is fine, is good as long as
So
there's
you're
somebody at the
concerned
other.
about the, I see, that there be identified, let's just say you talked about neonatal screening. So you're envisioning that maybe you'd have some heel pad test where you would measure autoantibodies, is that?
No, because you wouldn't expect them in the newborn.
So you would measure, what would you measure in that?
I wouldn't focus on the newborn at this point. I mean,
You
it's genetic. Dan alluded to genetic, risk alleles and stuff, but if you're going to do antibodies, it's going to be a later.
And that's our earlier discussion about when you would start that,
I mean,
Dan.
there is the T1D exchange, which I think is kind of functions as a registry
Yeah,
that enrolls a lot of people that are diagnosed with type 1 diabetes. I think it depends on the purpose of your registry and what you want to understand through that. Registries don't capture everyone. So in some sense, you're like large healthcare insurance systems are registries of a sort, and people often mine those for data. But of course, we don't have unification of those systems, which I think is what a lot of our European colleagues are helped by. They have registries, but they also have national insurance organizations that allow them to keep track of everybody. But it's a really important forward-looking question, right? Because if you're going to identify people with antibodies or with risk markers that might not get stage 3 type 1 needing insulin for a decade, 2 decades, like somebody's gonna need to know. Hopefully they know, but a lot of people do show up not exactly knowing all their health history.
Sure.
So it'd be helpful if they got the reminders to come get screened, if they got them more than once, like you get your postcard from your dentist to come get your checkup that you then throw in the trash until they send it to you a few times, right? But being part of a registry or some sort of other organized system keeps those people safe. I think we didn't really talk about, but like once you have the antibodies and you're going to get stage 3 at some point, and we talked about the benefit of trials and immunotherapies, but keeping you out of DKA is probably the most tangible benefit that you can receive. DKA is not good for you. And if we know you're getting type 1 diabetes, the European studies, other monitoring studies have shown that you can drastically reduce the risk of DKA just by knowing these people are out there and helping them. And that's where I think some sort of plan for that needs to be in place.
All right, we have another question from the audience. Cindy Leibarger, would you unmute yourself and ask your question, please?
Certainly, thank you. So my question is of a clinical nature. What about the use of Tzield for those with stage 3 type 1 diabetes, particularly those that may have some measurable C-peptide, the benefit of that? And is that feasible?
Yeah, I think we're gonna see that. I really do, but there was the initial recent study, which was not entirely approved by the FDA, and now there's some new enrolling studies to try to get some different endpoints for that. So I think we're just waiting to see at this point, but I truthfully don't think there's any reason to think that someone whose OTTT goes to 199 as stage 2 is fundamentally different from someone that goes to 210 and they're stage 3 and they both still have detectable C-peptide. It's again, just like we put cutoffs into studies in order to make the studies possible. And then sometimes those cutoffs come back to bite us in the behind because then they're implemented clinically as like, this is the way of doing things. And we don't currently have the freedom to make decisions about that. You go finagle things a little bit and try to do a couple of OGTTs and find yourself a stage 2 in there if you had someone that was close to the cutoff and you wanted to advocate for that patient, particularly people in strong honeymoons, potentially that come off insulin could warrant an OGTT to see if they're in stage 2. Now, we did have one kid post-TZIL go from stage 2 back to stage 1. So in our clinical experience, it does happen some of the time. So it's worthwhile thinking about. But yeah, I think, and then you got to think like even later than the first 100 days. What about day 101 or 115? Like, are they going to benefit? Well, probably. They still meet the criteria. Day 200. At some point, maybe not, but at some point, you don't have a whole lot of C-peptide to detect.
Okay, this has been a great discussion. So we're going to wind up, I believe, Monica and Alexis, we're near the end of our time. And so I'm going to ask you both to be a little forward thinking. So let's think about a decade from now. If we were having this discussion decade, what are going to be the issues and what do you predict are going to be the progress, and are there going to be new interventions, new ways to predict? Speculate a little bit for us as we close.
I'll leave the details to Dan. I want to bring up one point though. One issue that we haven't talked about that people have been thinking about is the environmental triggers to type 1 diabetes.
Yeah.
There's numerous dietary agents, infectious agents, and I'll just point out 2 studies. In Taiwan, they measured the rate of infection in children with enteroviruses, broad category of viruses, and showed that children who had an enterovirus infection had a roughly 50% increase in the incidence of type 1 diabetes clinically. Another study was done with a healthcare system. So the report was out of University of Michigan, but I don't think they identified the healthcare system, but this was 1.5 million children who were vaccinated for rotavirus. They got the rotavirus vaccine. They were looking primarily at the efficacy of rotavirus vaccine, and they showed that if you received the proper course, I can't remember if it was 2 or 3 injections, it had a substantial effect on the rate of hospitalization and so forth. But it also had over 10 years, a 33% reduction in the incidence of type 1 diabetes.
Wow.
So is that the answer? It's no, obviously not. There are multiple putative, triggers, but enterovirus has been a big one, and Coxsackie virus keeps coming to the fore. And I'm not prepared to really kind of get into the details of it, but particularly, I think in Denmark, there's a lot of interest in this, where they've actually been biopsying pancreases of people newly diagnosed with diabetes and identifying Coxsackie virus in the islets. So but is that the universal cause? I don't think there is a universal cause, but if you make sure everybody's got their rotavirus shots and they, et cetera, we might chip away at this.
Dan, you want to speculate on 10 years from now if we're having this conversation?
I just wanted to echo off that. I mean, I do think we have to be really thoughtful and careful about those discussions. I don't want any moms thinking, oh, my kid got rotavirus, and if only I'd avoided that one thing, he wouldn't have gotten type 1 diabetes. That's almost certainly not true, right? Environmental things are very much like a Plinko board. Like you ever watch The Price is Right, you drop the thing in the top, it hits all the things, it maybe falls in the type 1 diabetes bucket at the bottom. Maybe it doesn't, and all these environmental things are all over the place. So did those things impact your risk? Probably. Were they the definitive final cause? Almost certainly not. And if you missed the one, you're probably going to hit another in a few seconds. But I'm really hopeful like 10 years from now, we'll be relatively more efficient on screening. I'll have more people that are eligible for immunotherapy. I hope there will be immunotherapy in stage 3. I hope that it'll be multi-component immunotherapy. I hope endocrinologists will be like sort of rheumatology adjacent at that point, that we'll be doing these things in clinic, that people will be transitioning like immediately to closed loop systems, that there won't be this sort of long learning curve, that will be really helping people sort of maximize their early diagnosis success, particularly with preserving C-peptide. I do think that like the worse off you are with beta cell function, the worse your long-term outcomes are. So the more of that we can preserve is going to protect people throughout their lifetimes. Maybe we'll see some other hot things like islet cell replacement or artificial islets. That's something the immune system hates those, and it's going to be a long way before we see them in any kind of permanent replacement kind of situation, but I think we'll see more advances there, and those advances will give us more understanding of the fundamentals of diabetes that we then can target with agents that we already have.
All right, this has been a great discussion. So we'd like to thank Sugar Science for hosting us, and thank Drs. Moore and Russell for pontificating and answering some hard questions. But I think one of the things is that this is an incredibly exciting time for type 1 diabetes, right? While we talked about some of the challenges about screening and prediction and interventions, I mean, 10 years ago, we weren't having these kind of discussions, right? And so I think that gives great promise and great hope that things are moving in the right direction, and that next 10 years will hopefully have the same kind of progress. So thanks to everyone for joining online. And Monica, we're going to turn it back over to you. Okay.
It looks like that's it. It's
Great.
been very,
Thank you,
very exciting and interesting and deep discussion. Really appreciate the three of you taking your time. It's been a pleasure to be here at Vanderbilt and really have a deep dive into all that Vanderbilt offers. As a scientist or an early career scientist or clinician, it's a fantastic place to do type 1 diabetes work. And I would encourage anyone listening to this recording and to our site visit to learn more about everything that's going on here at Vanderbilt and Vanderbilt University Medical Center. Phenomenal place. Thank you.
Thanks again.
Thanks.